Great. Let's go to lab 3, Dr. Sharma and Dr. Dangas. Okay. Hello, we see you. Can you guys hear us?
We are just 1 second. We are
Oh, they're doing rotational atherectomy.
okay.
Okay.
Come out. Let's take it out, and we'll put the wire into the. All right, just 1 second. Guys, let me have this. Yeah.
It's a very complex case with multiple steps. We already completed a couple of them.
Yeah.
Okay,
Already completed a
94-year-old.
couple of steps.
Wow.
Okay. All right.
That's what
So
I saw.
let's go to the slide number 2. Case number 2 here.
Go back, please, to the presentation.
Good.
Yeah, there we
the
go.
94-year-old patient actually was referred for a workup of severe aortic stenosis and otherwise very feisty, fully alert, with the marbles, intact marbles and very sharp. Came for a workup, and of course we found very significant. Take a cine. And then I'm going to present this case now. Good. Put a wire in the LED later.
Yeah.
Okay, so this basically, what we found is a very significant, beside the severe AS, which we knew very tortuous groins, as you can see here, without flow, right?
Yeah.
So right coronary has a disease in the PDA, about 60–70%, and severe aortic stenosis, we did a balloon valvuloplasty. We wanted to just show the gradient. Should have taken the left side picture. Show the gradient here, show the pre-gradient.
So severe aortic stenosis, but can you just show us all the anatomy before you go to the balloon valvuloplasty?
Yeah, no, but just 1 second. The pre-gradient, can they quickly, so we don't have the left one yet. Can we show the picture? What?
Oh, they see it.
They see it, but why am I saying? Yeah, good. So that's a pre-gradient. And then we did a 20 and 22 millimeter valvuloplasty next. The post-gradient. So it became about 1/3. 90 gradient became about like 35, no AI. And let's come to the where meat is, or money is. Very distinct. Go back to the angiogram again. Very significant trifurcating left main.
Make angiogram.
Yeah, can you show us another view, because there's a
right here.
This view. Yeah.
One more view.
Good.
Very calcific chunk at the distal left main.
Make angiogram big, please.
1 and 1 and 1, and you see here. This
there
is the, I would say, the money shot. Takes care of classical 1-1-1, very calcific in this 94-year-old patient. What to do? So with this calcium, what we have done after the valvuloplasty.
Okay, so stop right there. So severe aortic stenosis, 94-year-old person with a severe left main trifurcation lesion. Dr. La Sala, how do we approach this?
So
Obviously, chunk of calcium sitting there.
So we're actually putting together a series of people who have high-risk PCI in conjunction with their aortic stenosis. This is obviously not too atypical. The one thing I would backtrack on is that we're going more to a true flow balloon for the valvuloplasty.
Yeah, that's what we use. We use a 20 millimeter true balloon.
A true flow, not a true.
True flow?
Oh, yeah. No, I mean, exactly. In this particular case, we were thinking about using the 20 millimeter balloon, and then, of course, the true flow, and then followed, didn't make a gradient change much, so we needed to go to a 22 millimeter ZMAT 2.
Okay. Can you tell us about the true flow balloon, Dr. La Sala?
Basically, is concentrically aligned balloons so that the central portion is open. Therefore, particularly in people who have low ejection fractions, and those that you don't want particularly to pace, you can blow up the balloon, you can leave it up for seconds, minutes, and you still have enough flow going to the center to not have any hemodynamic consequences.
To your point, doing a obstructed balloon valvuloplasty in a patient with this kind of
Can you
disease,
speak louder? I can't.
it's a little bit worrisome to do a balloon valvuloplasty if you don't have flow in this kind of a patient
Exactly.
with a coronary disease.
That's the point.
And that's the point.
But the
That's
true
why
flow, you need a big sheath, though. You have to use a 14 French sheath.
Well, he's going to get a TAVR, so there's going to be a big
I think we're seeing so many of these
right now, is he?
very complex patients, elderly patients coming in with aortic stenosis, and they have concomitant severe coronary disease. Raj, you have a large volume. Tell us about how you approach.
So, if the ostium of the left main is involved, then you really have the two,
go back and
preferably at the same time. So the ostium is not involved. It's the bifurcation here. We would still go ahead and try to do this at the time when we are doing TAVI, because you have the security because this patient can become unstable, and if everything is ready, the heart-lung machine is there, we would go ahead, do the left main first, and then just continue with TAVI.
So you would not do balloon valvuloplasty before? I think you would.
No, of course.
Yeah.
You know.
So everybody would do valvuloplasty, proceed, but you're saying you're ready to do TAVR as soon as you're done with this.
So you can have the wire across the valve.
I would have actually done the TAVR first.
Yeah, why not just do the TAVR first?
Mark?
I would do the TAVR first.
You would do the TAVR first?
Yeah, in the same setting as the left
In the
main.
same setting as the left
As long as the
main?
coronary heights were high enough and the
John?
elbow was okay.
We would actually put an Impella in after the BAV, and then go ahead and what I think we're going to see is a rotablator of the left.
Okay. Very interesting. Chet?
So to me, I think the calcific bifurcation left main is probably a trickier procedure than the TAVR. I would do the TAVR first, stabilize the patient, and then do a bifurcation left main as their...
Eberhard?
Yeah, I would do the same thing.
So a lot of the people here are saying TAVR first.
Wow.
And then to do this severely calcified.
TAVR.
Paul, would you do that? Not you.
I would do the,
No,
I'd worry a little bit about operating on the coronaries.
People are going with the ACC council recommendation. Remember that they came up with a document saying that in these patients, majority of them are getting the PCI first, 1 month later then you are doing your tower. So that has been the usual procedure, and that is what we have been doing. Very rarely in the low risk cases, in the certain, so this is the low risk case that we are doing a PCI at the same time of the tower. But this kind of a complex left main, I mean, this will be a very difficult, I would say, to do after the tower. We have written a great paper, and we'll talk about the access.
That's the problem. He's right. Sam, I agree with you that after the TAVR, of course, it depends what valve you use, but you might have some more trouble
No, but the coronary,
accessing this.
no, so
It looks high. It looks high here.
yeah, the coronaries look high enough, the sinuses look big enough. I would have done
You
it.
wouldn't have done a valvuloplasty either.
I would not have done a valvuloplasty.
No, I would have just done the PCI with or without atherectomy. If the balloons may expand,
would not do
you try them first. Keep it simple. You can.
Well, with the-
why not
Yes,
a
Dr.
valvuloplasty? Why not a valvuloplasty as Samin did just now? Opened up, there is no AR. It's quite safe to go ahead and complete the trifurcation now, and then decide if we can want to do the TAVR after.
There's nothing wrong with it, but you're doing the
That is
valvuloplasty to make the
exactly,
PCI easier.
that is what exactly we are planning here today. So we are doing the valvuloplasty, we are taking care of the left main, and followed by the tower in about 4 to 6 weeks. And that is what we have been doing in majority of our cases.
I would have just done this from the radial approach and without the left main.
TAVR, too. TAVR. He does the TAVR from the radio as well.
He would also do the TAVR from the radial. No. No. I think the idea of using the radial here for the PCI is absolutely is not a and it's definitely something to be considered. I think you used 2 burrs though, did you not?
Yeah, we did a
2 burrs?
1.75 for the circ and 2 burr for the LED.
7 French radial, you'll be fine.
On both sides, and you could have done radial, but I think, here you are, and you've already performed. So now what's your plan here,
Very
Dr.
simple.
Sharma?
It's a very complex, the 111, so we plan to do a mini crush after the lesion preparation. We still will require atherectomy, the atherotomy now, because clearly the burr actually has done some work, fracturing the calcium, but need to do still a lot more work. So this is the wire now, after 1.75 in the circumflex, the run-through wire. Then we have second run-through wire.
So now you'll go down the LAD.
Then cutting balloons, which size we have ready?
So how do you choose
3, 5,
which
and
one
4.
of the side branches to go down to do the burring? It looks like you did the smaller burr into the circ,
Yeah.
the larger burr into the LAD.
Yeah.
All the time you're absolutely ablating the left main.
Yes.
And you're not concerned about closing either one of those side branches during rotational atherectomy?
That is the whole advantage. That is one of the advantage of atherectomy, that it's not going to close the branch. We published long time ago, but as you know, but key is that yes, you are always concerned about it, but knowing that it's a very proximal, even if it goes down, that we can rapidly go back in. And so So anyway, this is now they have a fielder, as you know, those who have been using a run-through has been on a back order. Some issues with the America and Japan trade.
Oh, is that right?
Yeah.
Oh.
All the products from the Japan.
They're all in Dr. Tierstein's lab.
Yeah.
True.
So now what you're working with is a fielder?
Marvel.
Okay, give the marble.
Yeah, Marvel.
Okay. And so the idea here is now that you're going to do a mini crush. Anybody would use orbital
Shall make the
atherectomy. Mark Reisman, would you use orbital atherectomy over rotational in a case like this? Anyone here
I
on
think
this
you
panel?
can. I think this wouldn't be a bad case for it, but my experience with rotablade is so much more vast. I obviously be more comfortable with it, and
The
especially
sizes
controlling
go
it. in left main.
175 to the circuit, 2 on the LED.
Roberto, how would you approach this? Are you agreement with this plan as they're putting wires down?
This is amazing because this patient is not in any clinical trial, and I saw one similar case. Dr. Sharma did a similar case 1 month ago in his life.
The live case.
Then it's an operator decision to move forward. There are many topics to discuss. I would consider bailout rotablator for the left main. There is no data to support this, but anyway, it's a decision of the operator, and I will do exactly the same, except from the radio.
That's right. Does the technique of bifurcation matter in a case like this? If you just want to kind of do the fastest, quickest way, I mean, it sounds to me like the mini crush is a very good option here, or would you like to do the more fancy DK crush or culotte, etc.? Who wants to take that?
I think you should do what you always do, and you know how to do it best. So I think there are people who like to use...
But I think also you use the anatomy, right, to kind of make a decision of what's best and
It's
easiest.
simple, I think. Mini crush, micro crush, whatever you want to call it.
Yeah?
It's a good technique here.
Paul, you agree with that approach?
The fad right now is DK crush, right?
Right.
And I tend to use some taps still because they're easy. You're supposed to, this is not the left main, so you're supposed to use provisional if you can, but you're not going to like it because it's a big diagonal with a lesion in it, so you won't be happy with that. But you're supposed to start with provisional and see how it looks, but you're probably going to end up putting a stent in. So that's why I end up with a lot of tap, because I usually stent the main branch and then the diagonal if I have to.
It's interesting. You see that despite rotational atherectomy, they're going back in there with the Wolverine, right? Is that what you have, Dr. Sharma?
It's a 4 of Wolverine, because remember the region is, now it has opened up nicely, 16 atmosphere of the Wolverine. It is a little more forgiving than old Flextome, where we never used to go beyond 12. The Wolverine, easy to cross, and then it really gave, I would say, that you can go a little higher pressure. So in these cases, you try to do as minimum as possible, give a little bit of neosynephrine to keep the blood pressure over 100.
Yeah, how is the patient's blood pressure? And what did you think about using Impella, as John just
that after
said?
balloon valvuloplasty, so this is a few cases we have done, that where the tight disease of the left main, bad LV, this patient has a hyperdynamic.
Can we show the hemodynamics on the other one screen?
Yeah, it'd be nice to see the hemodynamics. It looks like the ventricle is not moving as well as I was seeing it before, but...
What pressure are they using?
120 over 60 is the pressure.
Can you ask the pressure inflation?
What pressure are you using on the Wolverine?
Wolverine 16, 14 to 16, large vessel because it's a very big vessel. So there's no 4.5. Now we are going to cut the circumflex and then go to our mini crush technique and use the app.
John?
I would just point out again, obviously, that because Samin is so experienced and so quick and so able to bail himself out of trouble as quickly, that he can get by without doing hemodynamic support, but you may not feel...
we have the 4 sheaths on the right side or no?
We have.
Yeah,
the right side.
Just to say, in this particular case, besides the valvuloplasty sheath, we have the 5 French sheath on the right side in case it needs it, so rapidly can be converted into appropriate whatever device support we need, Impella, balloon pump, and so forth.
So, Going back to the bifurcation
That wire in
technique,
the circ.
right? They have the wire, the circle. Now going back to the bifurcation technique, I think Samit can show side by side the bifurcate app.
Yeah.
So there is a question is what is the technique that we are going to go, right?
Yeah, I think also for the students in the audience, it's a nice, for the trainees, it's kind of
Is the
nice
app
to
being
see
shown?
with the app. No, we're not seeing it. You can put it in one of the, we don't need to see your faces. You can put the app there, and then we'll see how you're following.
Can they show the app? Yeah, app
we
is
see
coming
it
up.
now.
You
Yeah.
see that?
Yeah.
So that's also you can download. As we are talking, you can download from the App Store. The name is Bifurcate. So what you can see that as soon as you go in, the first thing you will differentiation is left main or non-left main.
Yeah.
So here we are going to take left main, right?
Yep.
You can
And it
see
was a
that?
111,
Yeah,
the very
so we are
first
talking
one.
111. Go to 111.
Take it out.
And as soon as we go to 111,
I mean, she's stable, but not really quite. I would say she's a little bit on the unstable side, but
no, I would say patient is still stable.
yeah,
Right?
because there's a good blood pressure.
We will go to
It's not
stable
shock.
situation here.
Yeah.
Because the
And this is the
unstable
picture we have. Yeah, this is the picture we have.
in the unstable
So far
situation.
dissections, but that's ready.
That's good.
Yeah.
Okay, good.
So there's a
In the
dissection along the superior wall of the vessel there, right?
Yeah. Dissection after the Wolverine with
Yeah,
the
which is
4
okay.
So the
Want
app,
the dissection.
what happens if you click on one of those? Does it do it for you?
Yeah. So why don't you press where you're gonna? You chose Mini Crush. So
No,
so put that.
Yeah, let's go to mini crush. So then it will take. So if it was unstable, we have said this is in the
Do a
situation of
V-scan.
cardiogenic shock that you can just do SKS and come out. But otherwise, you will have to now choose which one you want. The 3 technique we are talking there would
Yeah.
be
Let's choose
crush.
Mini Crush there, please.
Okay, go choose mini crush. So you
And then-
see, it's telling you wire both the vessels, right?
Yeah. And then
We are pre-dilating, both which we have done.
yeah.
Good. So pre-dilation is a key, whether you're going to take a NC balloon or you definitely have to use a atherotomy balloon. So if
Yeah.
you're not sure what you want to do, you have a menu button on the left corner. You go
Yeah.
there, you press the menu button, and that will tell you the basics of pre-dilation. What are the kind of pre-dilation things that you can use? When do you use atherotomy? That's one. And before that also it will tell you the kinds of wire you need to use and the wiring technique, if difficult wiring and all these things.
Yeah.
Good. So let's
It's
go
like a
back to the...
handbook on your phone. It
Yes,
really
good.
is very,
So
very.
now we have the stent
did a
selection
great
done.
job.
We are going to mini crush, and always the key is the same. You will go to the side branch first, okay?
Yep.
So you would go into the side branch, you go into the main branch. So as I am saying that, you can see live here what is
So
being
let's
done.
see what's going on live, because that's more exciting. I
No,
love
just
your
leave it
app,
aside.
but tell us what's going on with the live, Dr. Sharma.
They won't know what to do. You got to keep
Yeah,
going.
sorry for...
They don't
Are
know.
you
So that we
supposed
have to
to
tell
know
them.
these
So dilate the...
Why do you have to go to the phone? You're supposed to know these things.
So you are supposed... Yeah, stand.
That's what you think, Dr.
People are learning.
I think you're under the impression that everyone knows everything the way you know it.
But if you-
You'd be
if
very
you-
surprised if you put 100 interventionalists and tell them how would you
Just
do
see
a
the
mini crush.
case how
Yeah,
it goes.
if you
Then you
do these,
understand
you're
the steps.
supposed to know. Otherwise,
Tell us what's going on here.
So we are doing the left main, so the circumflex pre-dilation, which is a side branch. Okay, we are done there.
Yeah, right,
So-
right now live, we see the stent that was a stent in the circ.
Yeah.
And now,
Then after that, you remove the side branch
yeah,
balloon as well as the wire.
You're in the landscape.
Good. So the side
that.
branch balloon and the wire comes out.
So this is kind of an unusual view to deploy the stent in the circumflex. Don't you want to be a little more caudal to see the ostium better?
Yeah.
yeah, I think, it looks to me like they have plenty of, might not be as many as we might have imagined.
okay.
Maybe it'll be a micro now.
Yeah, I like to take a little test before I pull the wire out, just in case there is a dissection distal to the
No,
stent.
you want them
I
to
think he
test?
did do a little puff, it was
Okay,
fast.
good. And then you dilate the main vessel now. That's what's happening.
The stent. No. The
Are you still doing much SKS? You were popularizing that a few years ago.
No, not much
only
at
in
all.
acute
Only in the
situation.
case of an
We learned
emergency.
that on the long run. Go quickly one more. Quickly one more. One more inflation.
So, Samin, did you
long run
come
is the
back?
one.
No, okay, no.
I guess it's good.
The double barrel in the main vessel is not a great
Yeah,
idea
because what
after a
happened is
long
many
time.
times they came back and really tough to cross, although we have been able to do it very often. But in this particular case, now we have done the mini crush with the stent in the, you're right, the view may not be the ideal, but this is where we saw both circumflex ostium, we took multiple pictures, as well as the LED ostium.
Yeah, so in most cases,
Okay,
Dr.
so
Lasala
now
says,
this is a key
sir.
point. You see that the main vessel, the stent has been deployed, the balloon has come out. Now the side branch wire is still in the guide. So rewire the side branch with the same wire. If you are not able to rewire, then you can exchange. So take the main vessel wire to the side branch, and then the side branch wire which is in the guide, you can go into the main branch. So rewire now.
And you rewire, and of course you kiss, which is very
The wire
important.
is destroyed, give us a new wire.
Okay,
That
the
looks
wire is
pretty
destroyed, the
destroyed,
wire.
yeah.
New filter. And that's the thing, when you want to recross, always try to use a polymer coated wire. It's much easier to recross.
How
And
did the
usually in
patient
the left
tolerate that
main,
last
we will say
inflation?
when you want to post dilate, go with your NC balloons. So
Any other comments about the case, Eberhard? Would you do anything differently, or would you like the mini crush, Dr. Colombo?
No, I think very good. I think what is important here is the lesion preparation. They really did a very good lesion preparation with rotablation, cutting balloon. I think this is the key. Then the technique, I agree with Raj. You do whatever you like, whatever you're used to do. For bifurcation, you just need 3 techniques to know. Culotte, mini crush, and tap. That's it. 3.
So what do you think of the data, Antonio? That
I don't care about the data.
Okay.
I do not.
what do you say, mini crush tap?
Good point.
You're correct.
I don't care either anymore.
Yeah, so I guess a lot of people would say, why aren't you guys imaging here if you're so worried? I mean, I know it's a 94-year-old person.
Yeah,
trying to
imaging
get
will be
out.
done if you want at the end, not when we have this blood
At the
pressure
end, at
that's
the very
crashing. Yeah.
least. Do you need imaging? Who would hear
Now,
image?
see, this is what
on this?
we
I will
mentioned,
do
that
IVUS,
circ is
At
always
the end.
much easier to recross.
At the end, definitely image, particularly since these are very large vessels, and we're not tuned too much to seeing the difference between like a 4, 4.5,
I think when you
4.5, and
place
5.
2 stents, you
It'd be
always
grossly
have to do
undersized.
IVUS.
Dr. Sharma, did you hear that? When you place 2 stents, especially in the left main, you should do a final IVUS. What do you think about that?
Yeah, we have
Are you planning
Yeah, for the symposium only.
for the symposium only?
Symposium only.
No, I do think, though, in the larger vessels, we often underestimate.
Yeah, if there is a question, yeah.
And we might have, and then the question is,
Go.
what do you use, Doctor?
Go both.
Everyone here would uses IVUS
yeah.
imaging. Anyone uses OCT for the final? You use OCT, Paul, for your, would you even image here?
Nothing wrong in using it.
I know.
I use the IVUS map price like OCT. That's what I'm
Yeah,
Good, go. Siemens.
okay. So you see they're doing a
Okay.
kissing balloon
Yeah.
here. Give us the sizes of the
Yeah,
balloons you're using.
3.5 and 4.5. 3.5 in the circumflex, 4.5 into the left main LED.
Very.
And we are going to bring the picture. Are you ready in room 3? Want to go there? Or
Large
finish the
vessel.
OCT for your app. We'll
No,
take a
FFR.
picture.
Yeah, we're
No,
done.
take a picture. Yeah.
Now take the final picture here, yeah.
No, but it's good. So see,
So
they're still there.
only question is, when would you do
Okay.
pot in this situation is that if you are unable to recross
Go.
or you recross and you're unable to get your side branch balloon, that's the time we will say do the pot, but not routinely pot.
Beautiful.
Yeah, yeah.
Yeah, I know a lot of people do a lot of emphasis on the pot, but if you have done what we have shown through here, you see it that I put a 3.5 balloon through the stent struts, and so yeah.
Wire, pull back. Small branches.
But that's a bit.
All right. So what do everybody thinks? Do we need to do
Any
anything
comments?
more, or we are done here?
We're going to do some IVUS or something.
Everyone wants you to do some IVUS. Everybody here on
You want to finish your case? What do you want to show there?
Yeah, one of the things that'll pop up on the IVUS is that there was such a huge amount of plaque burden.
Okay, we go to the lab LED.
Do the tablet.
You're very
Okay,
likely
so
to see
let us know. Do you want to
We
stay
are ready
here,
for the
or
IVUS
do
and
we?
the LED now.
You're going to do
Are we
LED
done with the-
IVUS, or do we go to another room with
No,
Dr.
but we are
Kinney?
going to.
IVUS of
AK,
LED.
bifurcate app, you are done with that steps? Done? Okay, so we're just showing while Anu is getting ready in room 3 for another left main, and that to make everybody happy, and I'll tell you why, because there have been an access issue.
Good.
That just got dinged or something.
So Rox,
Yeah.
doing a TAVR now?
Sure. Come back here.
Now why not proceed with the TAVR right now?
You got
The
momentum.
pressure 160, 140 over 7, over 60 right now. Great result.
I would agree.
Let me also
not to
tell
do TAVR
everybody,
now.
guys,
Don't do
not from the
I
health
think-
point of view,
What?
medically I still think that they're making 2 steps separate, but again, the law, very few, even in the left main registry of Raj, the very few cases, like less than 10% had at the same time at the tower. Most of them done before, and that is the recommendation. Also, guys, I had to tell few things.
Please put the IVUS on
Yeah, I
the
was
main thing
going to put on
as we're
very
talking,
cost
and we'll
point
watch
of view.
you.
Now let me make the very important cost point of view. As such, tower has a lower contribution margin for the hospital because the valve cost. You add additional these devices at that time, the hospital is going to lose money on this very valuable procedure.
Yeah, well, these are really important.
Can you
We
show the IVUS?
minimize that,
Okay.
but it really, at the end of the day.
All right, I was in
important
the
to
left,
think about
LED
it.
to left
Actually,
main.
that's what I said to Chet just now. I mean, there's
Yeah?
the marginal financial benefit on TAVR
Yeah, coming towards the
only if you
stand
get
now.
your patient out in the first 5 days. If it's longer than that, or if you do something like this on top of it, you've just evaporated that margin.
Look at
Yeah.
this. What a beautiful.
It looks good, but I didn't know if the distal edge was actually well opposed, I gotta say.
We'll see it again.
I quickly glimpsed that, but I didn't see it fully.
Definitely the proximal is very well
Okay,
opposed.
show it from the beginning.
So, Raj,
Advancing.
you're happy with this?
I think this is a
Stop,
beautiful
bring the
result.
patient back when for the TAVR?
I think you can wait for a couple of months.
admission.
Couple of
The patient
months.
actually has had a balloon
The
valvuloplasty.
valvuloplasty should work. She's a lot better off than she started this morning, so, everybody happy with that kind of a plan?
I would
here?
probably bring it back a
but
little
you can
sooner.
also-
Most valvuloplasties
And I can tell you
are
another
gone in 2
point,
weeks.
guys, once you do more cases, the PCI, complex PCI with the tower, your pulse, because during that 30-second, when you are making 160 to 180, there is a region, some cases will have acute event, I guarantee you.
So I want to point one thing out hemodynamically.
So it looks like the distal edge looked good. I didn't really see it. I'm sorry. I was kind of distracted talking to the panel. But does the distal edge look good on there? And then if not, we want to go back to that first case in the OCT and try to see what happened
Okay,
in
this
that
is
first
where we
case.
are.
Okay, that looks good. Okay, looks good.
All right, we are done.
Very good,
Yeah,
Dr.
the imaging.
Excellent, excellent. Very great case.
Ready for
Let's
the
go
third
back
case.
to room 2.